As you may or may not know, Edith is a professor of OBGYN at the UW School of Medicine, and I do have to say that she is voted in Seattle's Best Doctors, Seattle Magazine. She gets chosen every year. I do not get chosen at all, and she gets chosen every year. She is the medical director, prenatal genetics and fetal therapy program, and prenatal and infant care clinic. Yada, yada. Okay. This is her here with her husband, Danny Fishbein, who's a cardiologist here at the UW. He also is selected by Seattle Magazine every year as the top cardiologist. I am not selected. And they got their two kids, two brilliant kids. I mean, you got your two brilliant doctors with two brilliant kids, so that's pretty cool stuff. And there they are in their ski outfits. They don't actually ski because they're too smart to do that. They just they put the outfits on and walk around. All right, so Edith, because she's so bright, she's not only in charge of OBGYN, but they also made her part of the internal medicine program here and medical genetics. She has a clinical expertise in prenatal diagnostics, genetic and maternal cystic fibrosis, and in women and fetuses with genetic conditions. Genetic conditions mean that you inherited something you probably don't really want. Okay. All right. So there she is. That's Edith with Danny. Danny, her husband. Is that Danny? Oh, yes, it is. And she earned her MS in genetic counseling, Sarah Lawrence College. This is not a college for silly people. This is a college for people that are winners. She completed her residency here at the UW. She's gotten a lot of awards, many, many awards. And now, with not much ado, I present Edith Cheng.
Well, it's my pleasure to be here, and I am going to take you from one end of the spectrum, which is how little we actually need in terms of medication and support to help mothers be safe and children to be safe, to the other end of the spectrum, which is what we do here at the University of Washington in taking a village to help mothers be safe and babies be safe. So I'm going to start with prenatal diagnosis because that's what I do. And these days with genetic screening, I don't really know where it begins. Do I begin at the embryo, the fetus, the newborn, the child, or the adult, or in the gametes? But I tonight am going to talk about the fetus. So why do we go through prenatal diagnosis? Well, really, all the time, really, I would say that it provides reassurance for the family to give them reassurance that the baby does not carry the genetic condition that it may be at risk for. But if the baby has a genetic condition, it may need special needs. And so it maximizes our management options for the baby. And sometimes it means termination, and sometimes it's continuation of the pregnancy. Within the maximal management, there's also prenatal therapy. Sometimes these babies actually need in utero therapy, either in terms of medication that we can give them or actually surgical intervention. These babies also may need neonatal support that can't be provided in their community hospital. So it allows us to plan for a delivery at a tertiary center like the University of Washington. It provides education for the family about their child's condition, but it also provides education for us in understanding disease processes. And it provides recurrence risk for future pregnancies, education about recurrence risks. So I think I show this slide to the medical students And I tell them that, you know, pregnancy is a dangerous state, and that it's fraught with all kinds of things like major congenital anomalies, 1 in 50 pregnancies, single gene disorder, genetic disorder, 1 in 100 pregnancies, a major chromosomal condition, 1 in 200. The chance that you will actually miscarry in the first trimester, which is defined by about the first 12 weeks of pregnancy, is 1 in 8. And that in North America, where we have incredible technology, the stillbirth rate is still 1 in 125. And the perinatal death rate is 1 in 150. So in spite of all of these numbers, I actually want to flip it and say it's a miracle that we're all here. It's a miracle for me who gets to see these pregnancies when they are 6 weeks old on an ultrasound and follow these pregnancies and deliver these babies, and that the cells and the cellular division and the differentiation actually goes correctly. So if you look at abnormal outcome and chromosome abnormalities, in the first trimester, miscarriages, 60% of them, if we did chromosomal studies on them, are abnormal. If you look at stillbirths and babies who died shortly after delivery, 6 to 7% of them have a chromosomal abnormality. So you can see that the chromosomes come in different sizes, and they have unique banding patterns that allow us to say that this is pair number 1 all the way up to the very top left, which is the longest chromosome, to the last pair, 22, and then by convention we always put the sex chromosomes, which is the X and the Y, in the lower right-hand corner. And this is this is called a karyotype. So it's a chromosomal picture of an individual with Down syndrome or trisomy 21. And if you look at the bottom row where the arrow is, there are 3 chromosome 21s. And it is the presence of that third 21 chromosome that gives you the clinical features that we see in Down syndrome. So who benefits or who should have genetic counseling? Is it a unique situation or what? Well, at the end of the day, really, in 2012, all pregnancies should benefit from genetic counseling. But actually, certain families should be referred for genetic counseling, and of course these are individuals in whom there is a chromosomal abnormality in a previous delivery, if there's a family history or a previous child with a known genetic condition, if one has had a child with spina bifida or neural tube defect, there's a recurrence risk for that. There's something called a positive prenatal screening test that I'll talk about a little bit later. And then ultrasound. I think everybody gets an ultrasound these days, and you can't help but every once in a while find an ultrasound abnormality in the fetus that we did not expect. These days, I can't talk about prenatal diagnosis without really presenting or talking about some parallel advances that have occurred in the last 30 years. And I have to say that I have had the privilege to be a part of that from the very beginning. Terry mentioned that I got my master's in genetic counseling at Sarah Lawrence. That was at a time when the field of genetic counseling had just begun. It was just a couple of years old. And I was recruited along with 5 other graduates from Sarah Lawrence to come out to the University of Washington, actually, because in 1978, 79, the university received a large sum of money to begin a clinical genetics program. And we needed people in prenatal diagnosis, we needed people in pediatric genetics, we needed people in adult genetics. And I've had the privilege to be the genetics counselor along with the physicians to actually start the prenatal diagnosis program here. So that was only a couple of years ago. So, you know, but it just actually shows that this field basically skyrocketed. It was just so fast in terms of its advancement. And part of it is related to radiology, just our ability to image the fetus. And I tell our medical students that ultrasound is basically living anatomy. As we screen, as we look at the fetus on ultrasound during pregnancy, we have glimpses of the embryologic development of the fetus. I don't know about you guys in zoology. Is anybody like at the U and taking zoology, embryology? I remember doing that at Berkeley, and we had cuts of the fetal chick, and that's how we learned embryology. And here you have the ultrasound that tells you the embryology. And now we have what we call 3D, three-dimensional ultrasound, and 4D is really live 3D. We now do fetal MRI routinely. Another prenatal screening is maternal serum screening, where we can sort of, through drawing the mother's blood and measuring certain proteins, we can sort of get an indirect idea of what the fetus is up to. And then, of course, a third group is the direct procedures, which is amniocentesis, fetal chorionic villus sampling, fetal corticentesis, and fetal tissue biopsy, which allows us to actually sample fetal tissue so that we can do some tests on it. And then lastly, pre-implantation genetic diagnosis, or PGD, so allowing us to look at the genetic makeup of the fetus or the embryo before it is actually in the uterus. And then most recently, fetal DNA, getting an aliquot of mother's blood and basically separating out some fetal DNA that's circulating in her blood, and then testing the genetics of that. But on the right-hand side of this is that we can't do anything in prenatal diagnosis, without the developments of science, and that is the cytogenetics and discovery of chromosomes. In 1952, 53, it was still thought that you and I had 48 chromosomes, okay? And it really wasn't until about 53 that Lejeune, who ultimately made the discovery that Down syndrome was due to trisomy 21, that he basically said in a tiny little paper that said, wait a minute, humans actually have 46 chromosomes. So I would have to say that that is in my lifetime that this happened. So the discovery of chromosomes, the bands that you saw, fairly new in my lifetime, and that was sort of, banding was in the 60s, certainly in my lifetime. All the biochemical analyses, certainly in the 60s and 70s. PCR, which our younger people now, particularly our medical students and our residents, just take for granted, is this incredible little box that if you take a piece of DNA, it just cycles it, and you get gobs of DNA that's made over and over again in a little box. The Human Genome Project in 1990 allowed us to sequence our entire gene. And then a number of very fancy microarray techniques. If you guys have not seen the film Gattaca, you should see that film, okay? So, goals of the prenatal diagnosis program. Why? Other goals? Well, we talked about maximizing options to families. Also, in doing this, there has to be timely information, transfer of information to the families. And at all times, there has to be respect for the patients and the family's ethical values and their decision options, because that's what we're here to do, is to give families options. So I'm going to quickly go over the procedures very quickly. Genetic amniocentesis is just a term for withdrawing amniotic fluid that surrounds the baby for genetic studies. It's done under ultrasound guidance. And you can see up here in the ultrasound, there is on the left-hand side, there's this tiny little dot. That's actually the needle in the amniotic fluid. And there's some 2 feet right there. That's amniotic fluid coming out of a syringe. It's yellow because it's basically fetal urine. And it contains cells that are floating around. It contains proteins and other chemicals that we can measure that can help us figure out what's going on with the baby. It's done between 15 to 20 weeks of gestation. It's always ultrasound guided. It's a gold standard international experience. The cytogenetic techniques of growing the chromosome, growing out the cells and looking at the chromosomes are very standardized, readily available, It's a relatively safe procedure with a pregnancy loss rate of, it's probably 1 in 500 or less, but the textbooks still talk about 1 in 200 to 1 in 400. So I tell the medical students that that's the answer on the test. What are the disadvantages? Well, it's done between 15 and 20 weeks. So most women identify that as being in their 4th and 5th month of their pregnancy. So it takes about 10 days to 2 weeks to get the chromosome results back. So there's a delay from procedure to diagnosis. So you can see later, I think, ultrasound vividly demonstrates the viability of the fetus. And if termination of the pregnancy is an option, then it requires a more complicated procedure than a first trimester. So in the quest to try and perform prenatal diagnosis earlier in a pregnancy, chorionic villus sampling, or CVS, was developed. It's essentially a placental biopsy that's completed between 10 and 12 to 13 weeks of pregnancy. Again, always ultrasound guided. There's a transabdominal approach and a transcervical approach, and I'll tell you what those are in a minute. The pregnancy loss rate is 1%, in spite of the fact that we've been doing this for about over 20 years. And there are some nuances in terms of culture failure and some ambiguous results. And this is one procedure that's absolutely dependent on the operator. In other words, not all high-risk obstetricians are trained to do CVS. There's a handful of us in the city who do CVSs. So not everybody is trained to do CVS, in contrast to genetic amnios, where just about everybody is trained to do that. So this is what it looks like from a transcervical approach. I kind of tell my patients that the transcervical approach just feels like the longest pap smear of your life, because it is a speculum in. And you basically, on the right-hand side with the ultrasound, you can see there's a bright linear line, and that is a catheter, a very thin, small plastic tubing that is going through the placenta and attached to a syringe, and we basically aspirate very gently just some tiny little placental tissue called chorionic villi. Under the microscope, they actually look like sea anemones. Abdominal approach is, again, I don't think you can see it very well, but there's again a linear line that comes down, and that's a needle, a long needle that goes through the placenta, and again you aspirate the villi. The benefits of CVS: it's an earlier diagnosis, and oftentimes the pregnancy, the confidentiality of the pregnancy is protected, because you're usually 10, 11, or 12 weeks. For some, people don't know, you don't show yet. Other reasons for doing CVS is that every once in a while we have DNA studies that are incredibly complex and can take anywhere from 4 to 6 or even 8 weeks to complete. And so we really want to get those tissue, the tissue that represents the fetus, as early as possible, so that we have time to get the diagnosis. And if termination of pregnancy is an option, then first trimester D&C is technically less complicated. As I alluded to earlier, the disadvantages is that the safety depends on the operator, so it's not readily available across the state. PUBS, or percutaneous umbilical cord blood sampling, is really an ultrasound-guided procedure that allows us to sample fetal blood directly by going into the umbilical cord of the fetus. We do it for diagnosis. So it's really no different than getting some blood, going to the lab and getting your blood drawn. The things that we can do on the fetal blood are the same things that you would get your blood drawn for. So we use it to make diagnoses, and we use it for therapy. So there are situations where there is a potentially fatal fetal cardiac arrhythmia, and we actually need to inject directly into the fetal bloodstream some anti-arrhythmic drug to stabilize the heart rate. There's a well-known disease called Rh disease, or hemolytic anemia, when there's Rh incompatibility, and the fetus actually becomes very, very anemic and goes into heart failure. And actually the treatment for that baby is a blood transfusion. And so we do pubs to access the fetal umbilical cord, and we actually give the baby a blood transfusion. It is, I think that for as complicated as this procedure is, the pregnancy loss rate or complication rate is actually less than 1%. And this is kind of a picture of what it looks like. There's a guide you can see up at the upper left hand, and there are two linear structures, two linear lines at the very, very top. And on this bottom here, you can see a little dot in this tubular structure, and that happens to be the umbilical cord, the vein, and the needle has actually gone in there. This just happens to be a color flow, and the blue swirl in there shows us that that is the blood of the fetus that's swirling through in there. Fetoscopy is something that we used to do, didn't do for a while, and now we're doing it again. It's a big telescope that allows us to actually visualize the inside of the uterus and the fetus and all the membranes and all the blood vessels. We used to do it for tissue biopsy. Back in the 70s and 80s, there were some genetic conditions that affected the fetal liver, and we could actually biopsy the fetal liver to make the diagnosis. Nowadays, we use it for all kinds of things, including placing shunts in the fetus. There's a condition called bladder outlet, where the fetus's bladder doesn't empty, and we actually place a shunt to redirect the urine out into a different place during the course of the pregnancy so that the fetus can continue to grow. So I want to just say very quickly that I don't want people to leave here thinking that I can just now walk into my OB's office and ask for prenatal diagnosis. We can only perform prenatal diagnosis if we know what we're looking for. So basically, there has to be a known diagnosis, or that whatever condition is associated with the baby is detectable in some form, i.e. A birth defect on ultrasound, or some biochemical abnormality in the amniotic fluid, or a known abnormality in the chromosomes, or in the DNA makeup, but we have to know what we're looking for, okay? This is just a picture of some of the DNA stuff that we do, using DNA to what we call paint the cells. And so these are just amniotic fluid cells that we've picked up. And basically on the left-hand, upper left-hand corner, you see 213s and 221s. These are just DNA of chromosome 13 and chromosome 21 that's attached to a fluorochrome, different colors, and we just splash it onto the cells and let it hybridize overnight, and then look at it under the microscope and count the dots. And so, whereas on the bottom, you have for the red, which is chromosome 21, 3 dots. And so we know that this fetus has trisomy 21. So we just went through all of what we call invasive screening, invasive testing, where I actually did something to get fetal tissue to look at it directly. Well, what about non-invasive? What about stuff that we don't have to directly impact the fetus or place the fetus at risk? And for those of you who've had babies recently or grandchildren or et cetera, you hear about, did you get that blood draw for that quad screen? Well, this is what it's all about. You measure different proteins in the mother's blood at different times during her pregnancy, and depending on what they are, they may give you an idea as to whether your fetus is at an increased risk for certain conditions. And the quad screen is basically 4 proteins: alpha-fetoprotein, AFP, unconjugated estrol, UE3, human chorionic gonadotropin, HCG, and inhibin A or INH. And in the quad screen, the pattern is such that a baby, a mom who is carrying a baby with Down syndrome will have an AFP that is lower than expected, a UE3 that's lower than expected, and an HCG and an INH that's higher than expected. It's not a definitive test. It is just a kind of a, odds. Are your odds bigger, greater than expected, or less than expected? There's another chromosomal condition called trisomy 18, where all 3 proteins are low. And then for neural tube defect or spina bifida, the alpha-fetoprotein is very, very elevated. So that's what we use to begin to think about whether a pregnancy might be at increased risk. Okay. There are other reasons that the maternal serum screening is done. For an obstetrician, sometimes it can be a warning sign for pregnancy complications down the road. It can also be a sign for multiple gestation if we haven't had an ultrasound yet. So it's generally just a red flag that something is not quite right and you need to move on to to counseling and some other level of testing or screening. So that was sort of blood work. So let's talk about ultrasound. So second trimester, these days most pregnancies will have at least one ultrasound. And oftentimes that's in the second trimester, and that's defined at somewhere between 16 and 22 weeks of pregnancy is when we would do the ultrasound. Some pregnancies now also get a first trimester ultrasound, somewhere between 11 and 14 weeks, to measure something called the nuchal translucency, which is a thickness in the back of the fetal neck, which can be a marker for a chromosomal problem. And here's an ultrasound of a patient that I saw in 1995. She actually came in for an ultrasound for another reason. This was expected to be a completely normal pregnancy. I think they got the ultrasound for growth. And when they got to the fetal heart, what they see here is the circular structure. And instead of having 4 chambers, they only see 3. And this is with the 2 upper ones being the ventricles, and the 2 which are the pumping chambers that pump blood out to your heart, and the lower single circular structure, the atrium, and there should be 2 of them. Well, this heart defect is actually called an AV canal. And when we see an AV canal, we're very concerned that this baby has Down syndrome. And so we actually did an amniocentesis on her. We confirmed that this baby has Down syndrome. And through that, we were able to basically make sure that the baby delivered at a tertiary center. She was going to be delivering at a community hospital. And we were able to have our Seattle Children's pediatric cardiologist on board so that this baby had all the care and the necessary care that he had when he was born. So that's ultrasound. Nuchal translucency, you can see, there's a thickness in the back of the fetal neck, and it changes, and you can see these little calipers up at the very top. They change with gestational age. We use it nowadays when it's super big, like this one on the left. We have to worry that this baby may have Down syndrome is at an increased risk. And the other is that we look for the nasal bone, which is also absent in about 60% of babies with Down syndrome. Pre-implantation genetic diagnosis. So now we're going to move one step even earlier, and that's before the embryo is even in the uterus. And we now have IVF technology where the 4 to 10 cell embryo is in a laboratory dish, and we can actually biopsy and remove 1 cell, and through PCR replicate and duplicate the DNA in that cell, and then perform genetic diagnoses, and then so that's PGD. So it's expensive. It requires IVF technology, and as I said, it usually at post day 3 of after fertilization, where the blastomere is about 4 to 10 cell stage, we biopsy 1 cell. And then what we do is the embryos that do not carry the genetic defect that it is at risk for will be saved, and the embryos that have the genetic defect will be discarded. And so that's embryo selection. So why would people undergo pre-implantation genetic diagnosis? Well, some families choose to do this because they want to remove a deleterious gene in the family. I have one family this woman whose brother had a very horrific heart condition. And she watched her brother and her mother and her family struggle through his heart condition. And he ultimately passed away at a very young age following the birth of his first child. And when when she was thinking about being pregnant, she actually came to me and said, I want PGD because I cannot possibly subject my family or my children to any of this. I want this gene out of my family. You can think about cancer situations, women who are carriers for BRCA1, breast cancer families, who want to have children and who want this gene removed from their family may choose PGD. Other families say that they use PGD because it avoids a termination procedure. So these are some of the reasons for PGD. And this is kind of what that 4 to 8 cell, 10 cell embryo blastomere looks like. And this is, you have on the left-hand side a pipette that's actually stabilizing the embryo, and then you have another pipette that's basically aspirating that one cell. And we have a whole generation of kids, basically, who are children from PGD, and at this point, we don't see that there are increased risk for birth defects or any issues. So what's the future? The future, I alluded to earlier in a slide, is what we call free fetal DNA and maternal serum. So we discovered that when we're pregnant, that the placenta is actually not very tight, and that it allows some fetal DNA from our current pregnancy to pass through the placenta and circulate into our bloodstream. And so technically, we can take a couple of tubes of blood from us, and again, basically extract the fetal DNA, replicate it by PCR, and run genetic testing for that. So that's kind of up and coming in the future, and I think that you will, for these guys who are going to be starting medical school and are in medical school now, it will be definitely in your generation that we will be doing this. Fetal imaging. I want to spend a little bit of time on that. You've kind of gone through what 2D ultrasound, which is the plain old black and white. 3D, we use now every once in a while. And this is a baby that has club feet. And it's hard to diagnose club feet on 2D, but on 3D we can diagnose that. And while in and of itself it's not, in the spectrum of what I do, horrific, it is for the family. But if we know this ahead of time, we can have them talk to the orthopedic surgeons and be prepared and know what we can do for the baby. So now I want to spend some time about preparing for the sick babe, very sick baby through prenatal diagnosis. These are 4 images. You have to take my word that on the left-hand, upper left-hand, this is a normal profile of a baby. You can see the forehead up there and a little pug nose and some lips. This is, in comparison, the last 2, micrognathia. So this baby, you can see the forehead, but unlike that profile up there, you can see a little bit of the nose, but it's almost like you don't see the chin. And you go, oh, I just did the scanner wrong. But whichever way we scanned, we couldn't find the chin very well. So we're very concerned that this baby has a very underdeveloped jaw and maybe a very small mouth. So we followed this pregnancy and into the 3rd trimester, and it continued and continued to the point where we just really didn't see a chin at all. So what we worry about is that if you have a very, very small jaw, you may not be able to open your mouth and breathe. And if one needed to intubate this baby and help it breathe, it may not be able to do that. So what are we going to do if we can't help this baby breathe? So, and this is what this baby looked like in 3D. We could not find the chin, and we were very concerned. So we did something, there is something now called the exit procedure, which is, remember that a baby, as long as it's connected to the placenta, breathes. That's mom gives it its oxygen and how it gets rid of its carbon dioxide. So we do a very special delivery procedure where we actually intubate the baby while the baby is still attached to the placenta. So we secure its airway. And then we clamp the cord and separate the baby from the mother. But now we've secured its airway. And so now we know that we can breathe. Now this isn't this baby. This is a baby that actually has a large mass under its chin, and it was blocking its airway. And we were very concerned that we would not be able to intubate this baby after it was born, so we did it while the baby was still attached. I think in all of this, I hope that you've seen that prenatal diagnosis lets us maximize options for the baby and for the family. Sometimes it is termination of the pregnancy. We just had a mom who we actually had to terminate because there was a situation in which we knew that if this pregnancy continued, she was definitely going to die. And she had a 9-year-old and a 7-year-old. And there are very few times in OB where we are definitely sure that the mother is going to die if she remained pregnant. But prenatal diagnosis allows us to plan all of these things for the mother and for the baby. I'm going to finish by saying that I've had the pleasure and the privilege of doing something full circle, which is to, in the beginning, to be involved in prenatal diagnosis where I've diagnosed affected fetuses and taken care of them. But I'm now at a stage in my career where the kids are coming back and as adults. And the other day I was doing an amniocentesis on this young woman, actually CVS. And she says, "Do you know blah, 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 blah?" And I go, "Yes, of course I do." And she goes, "Dr. Cheng, I'm her daughter." She says, "My mom said hi." So I think that this is a very special privilege. So now I get to take care of the moms who have grown up. And these are moms who had cystic fibrosis. These are moms who have congenital heart defects. These are moms who have all kinds of genetic conditions that I think technology have allowed them to grow up and be reproductive individuals. I'm going to go through this really quickly. I wanted to say that we have a very large cystic fibrosis center in Seattle. We are one of the sites, centers of excellence actually for cystic fibrosis care, the children's, and then we transition the kids up to our adult cystic fibrosis clinic. So I've had the privilege of taking care of women with cystic fibrosis and through their pregnancies, and we have great outcomes. So contrary to what you might think, our patients basically, this is something that we published in 2006, and we've had many, many more pregnancies than then. But I want to point out the fact that over half of our patients delivered at term, healthy babies that were 3,400 grams or greater. These are 7-pounders. So we didn't have any preterm deliveries less than 33 weeks, so that's excellent for us. And I want to say that that's important because if you look at, this came just out of the 2010 Cystic Fibrosis Foundation Registry, where the survival for our children with cystic fibrosis has really increased dramatically. Where in 2006, 2010, we expect that the median survival is going to be at least 36 to 40 years. And each year we actually get better and better. Lastly, I'm going to stop. I'm going to finish this with this. So I have a patient right now who came in and had an ultrasound. And we weren't quite expecting what we saw, but we saw this. And this is, we're looking at the long bones. And these are bones actually of the femur, so your thigh bone, and one of your tibia. And usually it should be a straight, perfect white line. And we see all these bends. And actually this one in the center here is a fracture with a callus. So this is a baby that has prenatal fractures and probably carries the diagnosis of something called osteogenesis imperfecta type 3. Okay. So again, she came in not expecting this, but we found this. And so I want to then say, what do we say to this mom? And what are her hopes and dreams for her child with osteogenesis imperfecta? And I'm going to show you what one's hopes and dreams are for somebody with osteogenesis imperfecta. So, and I'm going to introduce you to Charity Drummond and her mom. who's just going to tell us what it felt like a few bit years ago when she was told that.
My name is Anna Drummond, and I'm from Mississippi. And God had blessed me with 2 beautiful babies. But during the time that I was carrying these babies, I did not know that they had osteogenesis imperfecta. No one knew that they had osteogenesis imperfecta until the day that they were born. And each of them had fractured skulls, fractured ribs, and fractured legs. And when I was told this, I didn't know quite what to do. I was frightened. I was excited that I had twins, but I was frightened because I had never heard of this before. So during the time that we brought them home, we were taught how to work with them. And this was back in 1974, and there was not much known about osteogenesis imperfecta. But when the nurse came out and worked with me at home, the fear began to leave because they were just ordinary babies that needed to be taken care of and needed to be loved. And so they grew. We started to a special school, and when they turned 6 years old, they went to regular school. But during that time, I didn't want them to go. And I'm telling this like this because you're going to find out when I end up with this. I didn't want them to go, but they did go. So we went through elementary, we went through junior high, we struggled through high school. So I said, no, this is it. We're going to start right here. We're not going to go through this anymore because during that time there wasn't much accessible for them. But I said, no, we're not going to college. But guess what they said? They said, Mama, we are going to college. They said, you took care of us while we was young. Now it's time for us to take care of ourselves. And I thought, but oh no, you can't do this. We can't go to college. Because all I could think about was them, in the rain trying to go to class, carrying the heavy books. And that's, and it, to me, I was just frightened for them to do that. But they wasn't frightened at all. And so they started saying no to me about a lot of things. When they got ready to move out of my house, they didn't ask me if they could move. They just moved and then told me later. And so when they was going to move to Washington, I thought, Seattle, why? You all can't go to Seattle. But they told me they were going to Seattle, and they did. So one day I get a phone call, and I was told, Mom, I'm pregnant. You didn't ask me if you can do that. And I thought, oh gosh, my baby's pregnant. But I was happy about it, but I was also frightened about it. I didn't know what to expect. I thought about both of their lives, and, will my daughter make it? Will her baby make it? And we just began to pray about it. And so I got a phone call and to let me know that she was in and out of the hospital. So I caught the plane. But I didn't tell them that I was moving to Seattle either. So I moved here with them. But I am so proud of her. I said, my baby is having a baby. And when this little boy was born, and Dr. Cheng told me that there was nothing wrong with him. He's a healthy baby. I was so excited about that, because, your mind as a parent, just keep going back and forth. And then you remember what they have gone through, and, and the pain and the suffering. And I just didn't want her to have any pain anymore. But she stood up again, and she had a fine baby boy. And she went all the way through it and did not complain. And I'm so proud of her and what she's doing with this baby. I'm very proud of her. So thank you.
So I wanted to say that, baby Julian is actually going to go home today. Yes. He was born 8 weeks, 7 weeks premature, yes. But is a big chub right now, and he's going to go home. And
And I am very excited about that.
Very excited. And Charity basically let us, the whole team, do what we needed to do. She gave us some grief about some of the
I
things.
know, I was gonna say I
but she let us do what we needed to do to get her through and to have her have this healthy baby that she can talk to you about it.
And I definitely was. I was excited, but I have had like 23 surgeries on my legs and over 100 fractures. And so when I knew I was pregnant, I was excited, but then I was nervous and I was worried. So I wanted the best care possible, and I heard that UW was the place to be. So I decided to go to the hospital, and I was connected with Dr. Cheng, and she kept on saying, "We're gonna do this, we're gonna do this," you know. And I was so nervous, and I kept thinking, "So how long is it?" She said, "We're gonna make it to this many months or that many months." And my first thought was, if God can correct the word in 7 days, how come a woman had to go 9 months? that was my thought. That was my thought. I'm thinking the struggle. So each month I was counting down each month, and I mean my stomach was getting bigger and bigger. Dr. Cheng was saying, "And you're gonna get bigger." I said, "What? For real? I'm gonna get bigger than this?" And she kept on saying, "You're gonna get bigger, but it's gonna be okay." So I began to, you know, as the baby began to grow, I did have a little complication in my lungs. I couldn't, you know, my breathing, far as walking, I didn't want to walk. And far as exercising or anything, I was just really, really tired. The baby was getting huge, and I kept on saying, "Okay, baby, we're going to do this, we're going to do this." And my baby loved holidays, because every holiday something would happen. Thanksgiving, I ended up in the hospital, and I guess he hated ice cream, because I was going for ice cream, and I went into pre-labor. And I kept on saying, "No, I'm not in pre-labor." And then everybody was saying, "We need to go to the doctor." And I'm thinking, "No, I want some ice cream. I want to go get some ice cream." My whole thing was getting ice cream. So I'm sitting there thinking, okay, is this labor? So when I called triage, y'all know the number. So I called that number, and they told me to come on in, and believe it or not, I was in pre-labor. So I first learned about bed rest. So being in the hospital, I'm thinking, bed rest? Who in the world does bed rest these days? But I was in bed rest for 2 weeks, and that was, I was like, I'm all woman, I'm all independent, I'm going back to work. And so after bed rest for 2 weeks, I went back to work and got right back on bed rest. And so, believe it or not, babies do tell you what you're going to do. You don't tell the baby what he going to do. So my baby learned to lay on, my baby told me to lay on one side. No matter what side I chose, it was always the right-hand side. But towards the end, going into my 6 months, I kept on holding up a red flag. I'm ready. I'm ready. Let's do this one more month. I'm like, I'm ready. Let's do this now. Let's do this now. But I made it to 7 months. I was so excited. I don't think I would have made it without the support of my family. And like Dr. Cheng said, he's coming home tonight. And I'm like, okay, tonight. And we keep on thinking, how much sleep we gonna get? Probably none. Probably none. But I am so excited. I'm excited because I'm a mommy. I have osteogenesis, have a baby. My baby doesn't have OI. If he did, I would have loved him anyway. But wow, I made it. I made it through, and I was just so excited. And all the things I've done from eating, well, I didn't eat correctly. Sorry. I didn't. But, I mean, as far as taking care of myself and my family taking care of me, being on total bed rest was something that, for me, was great. And I'm telling you, the doctors at UW really helped me out. I stayed there 2 months. I was there so long, I put a sign on my door, "Knock before you come in. Just don't come in at all." But my mom stayed there with me the whole time. My boyfriend was there the whole time. My sister was there some of the time. Even though she's my identical twin, she was there some of the time. But I mean, this experience was wonderful, and so I am glad to say that my sister now is 2 months. And I said, "Dr. Cheng, I got you another one. My sister. And she was like, what? Because they told her mama drummer is coming in for an appointment. She thought it was me again. I said, no, no, no. It's her. So I just want to say that thank you guys for allowing me to do my little talk. After I had the baby, I did suffer a lot of muscle loss, weaknesses, and that's why I have this beautiful cane, which is cramping my style. But it's okay, and I have a wonderful scooter that also is cramping my style, but it's okay. I would do it all over again for him. Thank you.